and a warm welcome to this webinar. My name is Dr. Jonathan Sackier, and I'm thrilled to be moderating this discussion today. In this session, we'll be focusing on the power of artificial intelligence with the help of Dr. Bastian Sabel, a luminary radiologist at the University Hospital in Munich, Germany, who's committed to the development of AI-enhanced solutions. This webinar has been supported by a grant awarded by Siemens, and following Dr. Sabel's presentation, we'll conclude with what will hopefully be a lively question and answer session. Dr. Sabel will explore how AI-enhanced applications embedded in the clinical workflow can deliver actionable insights for cardiologists and elaborate on how AI-driven outcomes can enhance the quality of cardiology care. So, without further ado, I'll pass it over to Dr. Sabel to begin his presentation. Please sit back, relax, and enjoy.
Thank you very much for the kind introduction, Dr. Sackier. I'm very pleased to talk about radiology in times of artificial intelligence today, and more specifically about the AI Red Companion as supporting tool in cardiovascular imaging. Nicholas Taleb used the term black swan for the first time in his book on events in financial history. According to Taleb, a black swan refers to an event that is rare and highly unlikely, but often has extreme consequences for humanity. These events include, among others, the discovery of the American continent in search of a new path to India, the invention of the car, discovery of the antibacterial properties of penicillin, 9/11, rise of Google, and most probably also artificial intelligence. In recent years, artificial intelligence has found its way into everyday life in various ways. Intelligent computer algorithms are in internet search engines and at the speech recognition on smartphones, analysis of genetic data, photographic images, or upcoming self-driving cars. But what is machine learning? So computer programs are generally classified as artificial intelligence if they more or less imitate the cognitive abilities of a person and, for example, solve certain problems independently or are capable of learning. A newer and the most powerful form of machine learning is deep learning. Machine learning is often based on artificial neural networks, the ANNs, that is, computer algorithms that are not realistic models of the human brain, but are inspired by the neurobiological functioning and linking of real neurons. So one of the main motives in the development of ANN was the fact that even very simple brains, like such of flies and worms, can handle surprisingly complex tasks. So there are several factors that simultaneously drive the integration of AI into radiology. First, there is a discrepancy between the number of physicians trained in radiology and the increasing demand for imaging in many countries of the world. So this leads to a higher demand on work efficiency and productivity. And for example, the number of consultants in England, as you can see here, increased by 5% between 2013 and 2016, while the number of CT and MR scans increased by 29 and 26 percentage points respectively. Today, the average radiologist interprets images every 3 to 4 seconds, and this for 8 hours a day. So secondly, the image resolution of today's scanners improves continuously, and more data volume comes up. In fact, the estimated data volume for medical data is doubling every 3 years, which makes it increasingly difficult for radiologists to use the information available without additional help from computer-aided digital processing. Last but not least, diagnostic errors are still an unsolved problem. So studies show that about 4% of all radiological diagnoses misinterpretations occur, with an error rate being individually and heavily dependent on the procedure. For example, with the scans of the abdominal and pelvic region, the rate is much higher. In particular, accidental findings, for example, in chest CT are easy to overlook, which brings many liability issues. Artificial intelligence can probably help to overcome these challenges. Algorithms could therefore be a tool for efficient data-based image analysis as well as for diagnosis with few errors. As data plays such an important role, it is important to organize our thinking about the AI based on the data usage. At the first level here, we see the data generation, which is usually the CT or MR scanner. And AI contributes here to the automation of the work process and for fast acquisition and reconstruction. The next level then involves the immediate data use, which is, for example, the diagnostic itself. And one level higher, so the complexity increases. The data is then arranged around the patient. So this level is for prognosis, planning, correct treatment at the right time for the individual patient, the keyword precision medicine. In this context, we focus on not only on statistical models, but also on mechanistic physiological models, for example, the digital twin. So on the top level, this includes the analysis of the patient cohorts in terms of population health, result analysis, and resource utilization. So this is an example that is carried out by Slomka for AI usage in cardiac imaging. So on the lowest level, we here have the data processing, which would be automated extraction of image parametrics. This could be coronary calcification, stenosis quantification, and heart size. Then this is put together for risk stratification, like the Agatston score or other AI-based score that are not yet evaluated. Then put together with lab results, there is a scale-up, which means analysis and classification of clinical imaging variables. And in the end, there must be the patient benefit. So this could be personalized risk estimation for cardiac incidents and customized management and therapy plans for each patient. So Slomka concludes that these developments will not replace the role of the physicians, but will serve with accurate tools to detect disease and stratify risk, and therefore will optimize patient-specific treatment and further tests. An example of the expected transformation in imaging through automation. Let me explain this on the AR-RED companion. So what is the AR-RED companion capable of? So what is it? It is a well-trained algorithm that is able to assist radiologists in many ways. For example, by measuring the diameter of the thoracic aorta or highlighting suspicious lesions in the lung, and the list goes on. So the AR-RED companion is able to process the routine steps like highlighting, quantification, and measuring of anatomies and abnormalities. So the reporting of the findings in a structured report will be sent to the PACS system, to the radiologists, and with the AR-RED companion, radiologists will have the possibility to be supported by this augmented reading aid. So let me present to you the cardiac tool of the AR-RED companion. For this, two neural networks were combined, a convolutional network for image features and a fully connected neural network for spatial coordinate features. And also there is a coronary probability map and deep learning based aortic segmentation, which is used to exclude all non-coronary calcification. So here we see the axial images of the patient, where you see the automatic segmentation of the heart and also the highlighting and volume segmentation of the coronary plaques. You get the results also in numbers. So this is the coronary plaque volume, and this is the heart size, and this is all put together to the plaque severity score, which is moderate in that case. So the group around Joe Schupp from Charleston published a study in which the algorithm for the fully automated coronary calcium scoring of the ECG gated and non-gated CT data was validated. The validation of this algorithm showed excellent correlation between manual and AI-determined calcium scores, and also with the traditional scores, which you see on the left. So here you see there were no significant differences between the manual and the AI-determined calcium volumes. So in conclusion, the automated analysis could increase the workflow efficiency and could help to deal with the increasing number of acquisition requests in order to assist in the increased workforce of radiologists. So according to the authors, this would be especially interesting in screening situations. Another tool I want to show you in more detail is the automatic measurement of the aorta. So this is the tool itself. The algorithm has been validated by Siemens on different dose regimes, like low dose cancer screening with and without contrast enhancement, with diagnostic scans with and without contrast, slide thickness up to 3.2 millimeters, with 4 different manufacturers, and also hard and soft tissue kernels. So the landmarks are detected based on deep reinforcement learning. So the aortic root is used to define region of interest for the segmentation algorithm, and then based on the aortic mask, there is a centerline model, which you can see here, that is used to generate the aortic centerline. And then in the latter, this is used in combination with the aortic landmarks to identify measurement planes in all 9 locations, according to the guidelines of the American Heart Association. Let's have a look at a patient from our hospital. So these are just the axial images of our patient. Here we see the automatic measurements according to the American Heart Association guidelines, which are pretty accurate. And here you get the summary again, also with the measurements itself. And we tested also in a study if the ARED companion promises the time savings and reduced inter-reader variabilities you would expect. And we included 18 patients with ascending aorta diameters exceeding the population's mean by more than 2 standard variations, and who underwent 2 contrast-enhanced CTs in the interval of at least 6 months. In the results, AI assistant reduced the total diameter inter-reader variability of over 40%, and conventional and AI-assisted quantification of the aneurysm progress varied to small extent, so there was no significantly exceeding radiologists' inter-reader variabilities. But AI assistants, or not but even AI assistants reduced the reporting time by 60%, and AI assistant promised therefore significantly improved the reporting efficiency, and therefore we conclude that it has high potential to reduce radiologists' inter-reader variabilities that could hamper diagnostic follow-up accuracy. So these are the main cardiac tools. There are also some other tools regarding the thoracic imaging, like this one, which does the automatic quantification of lung emphysema. this one that does an automatic detection of lung nodules, and not only the detection, but also automatic measurements, both in 2D and 3D RECIST. And last but not least is the tool for the detection of vertebral fractures. So this is a case from our hospital where a vertebral fracture was detected by the AI-RAD companion. And we also did a study if this is useful for emergency whole body CT. And it came out that there are lesions like cardiomegaly, coronary plaques, aortic ectasia, and also lung lesions that are not reported in the initial report of emergency whole body CTs and would have been detected by the AI-RAD companion. And of course, most of the lung nodules, for example, are not malign, but some of them definitely are unclear and need some further up control. So in conclusion, we think the AI-RAD companion and AI in radiology can help to improve workflow and efficiency. So workflow through guideline-based automated recordings, automated consideration of preliminary examination and also progress quantification, automated transmission of result and structured findings, and improvement of efficiency through lesion highlighting, as we saw it with the lung nodules, characterization and classification, and integration of reference values and risk evaluations in the future. So I want to conclude and thank you very much.
So thank you very much, Bastian. It's a fascinating presentation, and I'm sitting here getting educated. So I guess I'll start with an aspirational question. How do you see the future? With the support of artificial intelligence, the patient's clinical pathway can change dramatically compared to today. Faster commencement of therapy, changing the treatment paradigm, better use of resources. What does the future hold, Bastian?
Thank you, Jonathan. Thank you very much. That's a very good question. I think actually we don't know, but as it is common with innovations, also with AI, tends to overestimate the short-term impact and underestimate the long-term impact. So in this sense, I do not expect AI to eliminate the radiologists or other medical specialties in the upcoming years. But however, I can very well imagine that radiologists will make use of AI-supported solutions in their daily routine, and especially in activities that require the detection or the measurements of lesions, as we saw with the AI-RAD companion. AI could help the radiologists to be better specialists, and I'm convinced that only a fraction of the information that is actually within the images, so within a CT or an MRI, can be processed by the human eye. And so AI offers great prospects for establishing into that direction, for example, regarding radiomics. And as I don't think imaging will play a smaller role in the future than it does today, so I think AI can help to achieve a higher effectiveness and efficiency in diagnostics.
Interesting. There's a lot of questions, so let's start with this one. Could you see this being correlated to biomarkers to support and inform drug therapy management? For example, plaque formation, plaque maturity, the way plaque might behave?
Well, this won't happen tomorrow, but there is a lot of data. We have a lot of data. We're gaining a lot of data every day, so in diagnostics and in therapy. And all this data is not connected yet. But this is, I think, our That's our job. Our job is in the first line to make data adjustable, so that we can store data in machine readable forms. And then in the next step, we can try to get this data connected and to get a further use of it.
So many years ago, when I was training, we were told that when you request a chest X-ray from a radiologist, do not just write chest, because you might get a report back that says chest present, right? And as things have changed, professional relationships between specialists have changed. Can you speak to your professional relationship with the cardiologists in your institution? Because this technology strikes me could fundamentally change their role. What's their reaction on it? What is effectively a proactive approach from you using artificial intelligence to assess cardiac size, coronary artery calcification or CAC, thoracic aorta measurements for every chest CT?
Mm-hmm. So we, at our hospital, we are in the lucky position that we could help to develop the ARED companion. But to date, we do not have the ARED companion in clinical routine. However, we have recently received the privacy clearance and will hopefully be able to use it for patient care in our hospital very soon. So I hope I will be able to report to that particular experience in the future, but by now I unfortunately can't. So by now we have the ARED companion on a research server, and we could use it for a very special amount of patients and with a certain indications for imaging. And for that, so our first evaluations or our first results say that there are two ways to use AI in daily routine. The first one is for incidental findings. So the radiologists or the doctors, not only the radiologists, are good if they have a request and they answer this request. So there are only a few very certain algorithms that can be better than the doctor right now. But a part of that, the radiologist also has to interpret the whole image. So the image goes to the border, we say, and so there can be incidental findings that are not in focus right now, but can be very important for the patient in the future. So, for example, if you look for pneumonia, but the patient has lymph node metastasis, that wouldn't be seen otherwise, for example.
So that actually speaks to another question: is the tool set up to detect a specific abnormal finding, or do you need to prompt for specific items? How does that work?
Yeah. So that's up to you. So as a radiologist, you can, so the ARED companion does all the, it is a combination of different algorithms, and every algorithm is carried out for the data set it fits to. So if you put in a thorax CT, for example, in that case, then all algorithms are carried out. But it's up to the radiologist if he wants to reject or if he wants to accept the results. So so you don't have to ask, please do me all the coronary calcification measurements or anything like that, or the emphysema quantification, whatever.
Okay. And, you know, when AI was first prompted as a solution, there were a lot of people, a lot of even very prominent scientists who were terrified that AI represented the end of humanity. We've heard that before, right? But I think we all now understand that the potential benefits of artificial intelligence are huge. In this circumstance, you know, even a dullard like I can see that it's huge. But what are the main limitations, Bastian?
The primitive forms of artificial intelligence developed so far to have already proved to be very useful. But I think today we cannot estimate if the consequences of creating something that can match or surpass the humans. We cannot estimate the consequences of that. But I believe so for our lifetime, for example, or for the upcoming decades, we will remain in charge of the technology for a long time and can use the potential of it to solve many problems in diagnostics.
So how fast and how easily is this new technology adopted in clinical practice? And what did you experience as the biggest hurdles to implementing it and not be seen as taking away expert knowledge? I remember I was working when the extracorporeal shockwave lithotripter was introduced into the hospital, and the urologists went crazy because this represented a threat to their ability to do transcutaneous stone extraction. And then they, ping, a light bulb went off. Heck, all we have to do is press a button and it does the same thing, much nicer for the patient, much easier for me. So can you answer those questions, please, Bastian?
Yeah. So what will be the next step? So I think
the hurdles. What are the hurdles?
The hurdles, of course. So there are already some algorithms that can answer some certain questions, like find me a pneumothorax, for example, detect pneumonia in chest X-ray, for example, or quantification of the brain parenchyma, for example. So there are certain algorithms that can do that. The next problem or the next hurdle will be to bring it into clinical practice and to get radiologists to trust into these solutions. That's the first one. To get it implemented in the regular workflow. So, for example, as a radiologist, if you have to open another software system just to detect different lung nodules, for example, it's too much effort that you would actually use it in daily practice, and you would just do it your own, and so it would never find into clinical routine. So that's another thing. Not only get algorithms that are trustworthy, but also to get it as capable or as usable in daily routine that they can expand and can be efficient and bring benefits to the radiologist, and in the end, most importantly, of course, to the patient.
So you didn't have cardiologists sort of putting up a brick wall to stop you getting into the suite where you have this installed?
No, we didn't. So no, we didn't. But we worked with vascular surgeons, for example, for the aortic measurements, and they were happy and were happy with the measurements of the aorta, for example, because it is very time consuming. So if you do that for every patient, even if it is not requested, of course, if it is requested, that's part of the job. But if you do a staging or have an emergency room CT, whole body CT, for example, then you wouldn't do all the guideline compliant measurements with every patient, because it takes about 13 minutes to 14 minutes, about something like that. And that's a lot of time if it is not of any use. But with solutions, with the AI solution, it's just a click. It's or not even that, and you can find out some patients with aortic measurements that exceed the normal diameters that would probably not be detected otherwise.
Well, you mentioned just a click. If it's just a click, can you see this technology getting to the point that, I wouldn't say that you're not needed, but you're not needed there, that this test could be administered by another type of clinician, another kind of healthcare worker? A nurse can be trained to do this. Anyone can be trained to do many tasks with a physician like you looking at the results thereafter, and thereby improving workflow and reducing demands on your time. Is that going to happen, do you think?
Well, I think it would change the role of the radiologist. So right now, a big part of the radiologist's job every day is to detect, to measure, to quantify. And all these things can be done by a computer, can be done by an algorithms. I think the job of the radiologist will then be to, or it is also right now, but it will go more into the direction that interpretation, bringing together all these numbers, all these counts, measurements, and findings, bringing it together to a report that is of use for the treating clinicians. I don't think, but future will show that this is all. That the technicians will just do it themselves, and the images or the AI results will just be sent to the treating clinicians as they are. I don't expect that. I think the radiologists will have more time to concentrate on also important, and if not more important, aspects than detecting and measuring lesions. And right now, that's also part of our job, but sometimes we are running out of time to do it properly.
Yeah. I mean, I personally always enjoyed, as a surgeon, the interaction with my radiologist and sitting down and looking at things and avoiding meaningless commentaries. So if I need a CAT scan on a patient who's 2 days post-operatively from a laparoscopy, for instance, I don't need to be told that there is air in the abdominal cavity. Of course there is. You know, we've made a hole in the integument. So I'm a big fan of that interdisciplinary discussion. I want to ask you, I'm sorry, go ahead.
No, I just want to add, so yeah, that would leave more space for the interaction with the clinicians, with the surgeons, and with the patients.
Yeah, absolutely. I do have a technical question. I want to ask you to expand on 2 phrases you used: deep learning and artificial neural networks. For those new to the space, can you just expand and tell us what those phrases mean?
Yeah, so deep learning is the most, so deep learning is part of artificial intelligence. So artificial intelligence is just if the big field of this part of informatics and engineering. And deep learning is the highest profession. I myself, I'm not a professional in informatics, so I can go into depth with that. But many things right now that are called deep learning, sometimes it's only marketing, to be honest. Sometimes, the AI algorithms with deep learning, you don't give too many borders for the algorithm to find the ways how to to get to certain results.
Do you think that there's a question here about the impact for lesser developed countries where there's a bigger gap between radiologists who are needed? Do you think it could play an even bigger role in such circumstances?
Absolutely. So, for example, there was one study carried out in there was one study about the detection of tuberculosis in X-rays, in chest X-rays, and so this group combined two algorithms that for the detection of tuberculosis, and only if these two algorithms didn't agree, a radiologist was called to make a decision if there is tuberculosis suspicion or not. And of course, so you need less, only a little number of radiologists, and of course, in less developed countries, you can get more expertise with less people, less radiologists, whatever. And you don't even need to go that far. Also, you can see in smaller hospitals in the countryside, or even in smaller cities, there isn't a radiologist there for 24/7. So sometimes a radiologist is there in daily routine or for certain cases on demand, but he isn't there for every chest X-ray. And for example, you can use the resident in the emergency room has to interpret the chest X-rays by himself. So as he is not that experienced, usually some pathologies like pneumothorax, for example, can be overlooked. And if you have another algorithm in the background that can screen it, can maybe highlight some findings, then also, and again, the patient can profit with AI.
So there's a number of questions here, Bastian, about coronary artery disease and what role artificial intelligence might play in the interpretation of coronary artery lesions, even in the cath suite, in the catheterization suite. Is that where this is going?
Absolutely. So there aren't any borders. So I think in the coronary artery plaques, the quantification, again, this is something that is not carried out if it is not requested in the CT. Maybe it is mentioned in the report usually, but it is not quantitative. So even maybe if the patient has a row of CAT scans, then the development of the coronary plaques is usually not quantified. And with AI, it would be easy to quantify it. It would be easy to see the development, and it would be easier to get early therapy, like statins, for example. And in the catheter, in the angio suite or whatever, we can also. So I could imagine we could also see AI there, but I don't know of any solutions right now. I would have to look it up.
Yeah, well, I'm sure
somebody who's working on that. I'm sure there is, but I don't know of.
Sure, people are looking at that, absolutely, especially in certain areas where outcomes are technique dependent. So I've got some data here that there was a recent study of radiologists reporting coronary artery calcification scores during lung cancer screening CTs, and it raises the possibility, the opportunity to raise awareness of atherosclerotic cardiovascular disease risk and thereby impact preventative statin prescriptions. What do you think about that?
Yeah, absolutely. So that makes absolute sense. I think so. That's again, that's a good example of incidental findings that wouldn't have been overlooked, but wouldn't have led to treatment. Or this is a good example how AI can change patient management. And yeah, we will see. There will be a lot of similar solutions coming up in the future, I think.
Well, we're going to come on to the future in a minute, but I've got a question here, which is technically way beyond my limited intellect, but how are data sets being collected and validated to then be used in algorithms? And presumably this is based on pattern recognition.
Yeah,
what's meant by machine learning, right?
Yeah, that's very critical, actually. So there are big data sets available for, let's go back to chest X-ray. So there are big data sets available where people can train their algorithms. And sometimes these are very experienced groups within the field of informatics, but there are solutions out there that have impressive areas under the curve for the detection of pneumothorax, for example. But we, as our work group, did a subgroup analysis, for example, of one. Did a subgroup analysis for that, and then we found out that many of these algorithms don't really find or don't really detect the pneumothorax itself, but as they were trained on open data resources, they were just able to detect the thoracic tube. And so that is very important. So what do you have to do? You really need to know what data are you using for training, and what is your algorithm looking at. And so these are very critical, two really critical things that we will go more into depth within the next years before we will see, or side by side with the integration of AI algorithms in the clinical practice.
Well, one of the questions that's popped up is a very good one. It's saying currently few medical schools are teaching formal courses on AI, and it provokes all sorts of jokes in my mind about my medical school days and our grasp on any intelligence, artificial or real. We're going to have to bridge the gap, right, so that people don't view it as, you know, based on science fiction rather than science fact, that this is a powerful tool that has the basis to fundamentally change the way we practice medicine in a very good way, right? Yeah. How do we do that, Bastian?
I think the problem is we shouldn't look for AI solutions that can solve one problem at once. But we should take the baby steps to that on that way. So little tasks, little solutions, little benefits, and then in the whole, these algorithms all together and implement the wise implementation of these algorithms will then lead to the real benefit. So I think we shouldn't want too much in the beginning, and then we will gain a lot of benefit out of this technology.
Right. So in 2011, you were a fellow at the Harvard Medical School, Massachusetts General Hospital, and the Center for Biomedical Imaging. How fast has this technology developed, and how much is it's grown? I mean, to me, this is amazing.
Mm-hmm. Yeah, so back then we didn't do anything with AI. Are you referring to AI or the flat panel CT right now? I think AI, right?
I mean, I'm old enough to remember the introduction of CT scan and PET.
Yeah, so AI wasn't a big story. It was a big story back then, but nothing compared to now, to today. And flat panel CT, of course, it has some benefits. It has benefits like the scanners have a larger area of the detector, so they have a wider Z-axis area of coverage, but and therefore they have a high spatial resolution. But on the other hand, they are pretty heavy, the detectors, and they can't reach the same rotation speed as a conventional multi-detector scanner can. And so far, they didn't. They aren't in use in the clinical routine in the radiology departments as multi-detector CTs are. So,
well,
a little bit, yeah.
Yeah, again, I'm thinking back about the genesis of medicine, and they say that 5 years after you leave medical school, 50% of what you learned will have been proven to be incorrect. The problem is which 50%. It's an exciting time to be alive. So I guess the final two questions I want to ask you: what's next in the world of AI in healthcare more globally, and what's your biggest wish within your specialty with AI in radiology and cardiology?
Mm-hmm.
And you can be as aspirational as you wish.
What's next? Yeah, I think the next thing will be the implementation. So focused tasks and the implementation in clinical routine. And yeah, I would wish that way that we would maybe we would get more trust into this new technology, and I think that's part of our jobs. So that's not part of the informatics professionals' jobs, but that's our job, or as doctors who are using this this technology.
Well, I think that about wraps it up for today. I found this a fascinating discussion, and I hope you, our audience, agree. I want to thank Dr. Bastian Sabel for the amazing journey you've taken us on, and I personally cannot wait for the next update on your work. I didn't even know this stuff was going on, so thank you.
Thank you very much for the opportunity, Jonathan.
I just want to make a couple of closing comments. You know, when the Large Hadron Collider at CERN near Geneva was about to go live, there were fears among the uninitiated that universe-gobbling black holes would be created and end the world. Nonsense, of course. And the same sort of ill-informed commentary constantly hampers medical developments. But AI is here to stay, and as we've seen, it's providing obvious and evolving benefits for patients and the clinicians who serve them. I want to thank the good folks at Siemens who I've collaborated with in the past, and I thoroughly enjoyed that experience. I know that the Siemens Healthineers group is focused on being trusted partners in this artificial intelligence innovation journey. And I also want to thank them for supporting this webinar. I also want to recognize the lovely folks at EMG for making the technical magic happen. That's totally beyond me. And you, our audience, for taking the time to participate. You know, Albert Einstein said that the mind that is open to new ideas never returns to its original size. So stay safe, stay well, and keep your minds open. From Dr. Sabel and I, bye for now.
Goodbye, thank you.